Welcome to the deep dive. Today we're taking a plunge into something absolutely fundamental, how your body gets the oxygen it needs, the incredible teamwork involved, and what happens when that system faces challenges.
Right. We've got a really rich source for you today. We're digging into exam3objectives.pdf, which, well, don't let the title fool you. It's packed with crucial insights. Covers everything from the minute details of how your lungs work to how healthcare professionals step in when things, go wrong.
Exactly. Our goal for you on this deep dive is to make all of this clear and fascinating. We want you to walk away with a real understanding of breathing, how your blood becomes oxygen-rich, and the heart's absolutely vital role, those aha moments, without getting lost in complicated terms.
Okay.
Okay, let's unpack this, starting with the very thing that keeps us going, breathing.
So at the heart of it, we have the cardiopulmonary system. Your lungs and your heart operating as like a seamless unit. Think about taking a breath in, inspiration. That's an active effort. Your diaphragm, that big muscle right below your lungs, it tightens and flattens, and the muscles between your ribs, the external intercostals, they lift and expand your rib cage.
And all of that movement creates more space in your chest, doesn't it? It pulls things open.
Precisely. This expansion causes the pressure in the pleural space, that thin area between your lungs and chest wall, to become negative. Less than the air pressure outside of you, which at sea level is about 760 millimeter Hg.
Wow.
Think of it as like a gentle vacuum suctioning your lungs open. This negative pressure is absolutely key to keeping your lungs inflated.
So that seemingly small pressure difference is the foundation of every breath. A
Hello.
tiny margin that, well, if it gets disrupted, things go wrong fast.
That's it. That negative pressure is crucial.
Negative pressure, fascinating. And breathing out, expiration, that's the reverse, right? A passive process, as I understand it.
That's right. The muscles simply relax, your chest cavity kind of recoils, and the air is naturally pushed out. Now, when we talk about the work of breathing, or WOB, in someone healthy, all of this happens so smoothly, you almost don't even notice.
Like it's on autopilot.
Pretty much, yeah.
Exactly. The document also highlights some important lung volumes. Tidal volume, that's the normal amount of air you move in and out with each regular breath.
Yep, your everyday breath.
Then you have residual volume, that's the air that always stays in your lungs, even after you've forced out as much as you possibly can.
Like a little reserve.
Right. And forced vital capacity is the total amount of air you can forcefully exhale after taking the deepest possible breath. So these volumes give us a way to measure how well your lungs are functioning.
They're good indicators, yeah.
One more thing mentioned here is surfactant. That sounds really important.
Oh, it's absolutely vital. Surfactant is a substance your lungs produce that reduces the surface tension inside those tiny air sacs, the alveoli. Imagine it like a bit of soap and water. It makes it easier for those tiny sacs to expand and, crucially, prevents them from collapsing after you exhale. Without enough surfactant, taking a breath would be incredibly difficult.
Right, like they'd stick together. Okay, so we've got air moving in and out. But how does that oxygen actually get into our blood? That's where gas exchange comes into play, isn't it?
Exactly. This involves three crucial steps: ventilation, perfusion, and diffusion. We've already covered ventilation. That's the movement of air into and out of the lungs.
Got it. Breathing in and out.
Perfusion is the flow of blood through the tiny blood vessels, the capillaries that surround those air sacs in your lungs.
Okay, blood flow to the lungs.
And diffusion is the actual movement of gases, oxygen, and carbon dioxide across the incredibly thin barrier between the air sacs and those capillaries. That's the alveolar capillary membrane.
So ventilation brings the fresh, oxygen-rich air right next to the blood vessels, and perfusion brings the deoxygenated blood from the heart there, too. Then diffusion is where the magic happens, the actual swap.
Precisely. Oxygen moves from the air in the alveoli, where there's a high concentration, into the blood in the capillaries, where the concentration is lower. Simple diffusion.
Down the gradient?
Yep. And at the same time, carbon dioxide, which is a waste product your body needs to get rid of, moves from the blood where it's concentrated into the alveoli to be exhaled. Now, the thickness of that membrane is critical. If it gets thicker, say due to illness or inflammation, it becomes harder for those gases to move across efficiently. Gas exchange slows down.
That makes sense. It's like trying to talk through a thicker wall. And the document goes into some detail about how carbon dioxide is transported. That's a bit more involved than just dissolving, isn't it?
It is. It's quite fascinating, actually. Carbon dioxide, produced by your cells, diffuses into your red blood cells. Inside, an enzyme quickly helps turn it into carbonic acid.
Okay, carbonic acid inside the red blood cell.
This carbonic acid then immediately splits into hydrogen ions H plus and bicarbonate ions HCO3. Think of your red blood cells as miniature chemical factories, constantly converting this waste product.
A brilliant bit of biological engineering.
It really is.
So the CO2 essentially gets transformed inside the red blood cell.
Exactly. And hemoglobin, the protein in red blood cells famous for carrying oxygen, it also acts as a buffer here. It binds to those hydrogen ions, which prevents the blood from getting too acidic.
Ah, clever. Multitasking protein.
Meanwhile, the bicarbonate ions in HCO3, they actually move out of the red blood cells and into the plasma, the liquid part of your blood. And this bicarbonate floating in the plasma is actually the main way carbon dioxide travels back to the lungs.
Wow, okay. So it's mostly carried as bicarbonate. That's a neat chemistry. Okay, so the lungs get the oxygen into the blood and get rid of the carbon dioxide. But how does that oxygen-rich blood then get to, well, everywhere else? That's where the heart takes center stage.
Absolutely. The heart is the engine driving this whole system. Its electrical system is key. It starts with the SA node, the pacemaker.
Right, the sinoatrial node.
Then the signal travels to the AV node, down through the bundle of His, splits into the right and left bundle branches, and finally reaches the Purkinje fibers spread throughout the ventricles.
And that whole pathway triggers the muscle contraction.
Exactly. It generates the electrical signals that make the heart muscle contract in a very specific, coordinated way. A disruption anywhere along that chain, well, it could lead to a really ineffective heartbeat.
So that electrical signal ensures the heart beats rhythmically and effectively, pushing the blood out.
Precisely. This electrical activity then leads to the mechanical pumping of blood. The cardiac cycle has two main phases. Diastole, when the heart's ventricles are relaxed and filling with blood.
Filling up.
And systole, when they contract forcefully and push that blood out. The amount of blood ejected with each single beat is called the stroke volume.
Stroke volume, okay. And this pumping action makes sure the blood flows in one direction only, doesn't it? The document mentions the heart valves.
Yes, absolutely crucial. The four heart valves, mitral, tricuspid, aortic, and pulmonic, act like one-way doors. They ensure blood flows in the correct direction and doesn't back up.
How do they do that?
Well, when the ventricles squeeze during systole, the mitral and tricuspid valves snap shut. That's the first heart sound you hear, S1, the lub sound. This prevents blood from flowing backward into the upper chambers, the atria.
Got it. Lub.
Then, the aortic and pulmonic valves open, allowing blood to be pumped out to the body and the lungs. When the ventricles relax during diastole, the aortic and pulmonic valves close. That's the second heart sound, S2, the dub sound. This stops blood from flowing back into the relaxing ventricles.
Lub-dub, lub-dub. So those sounds your doctor listens for tell a story about these vital valves working properly.
Exactly. They're listening to those valves closing. And we can't forget the pulmonary circulation in all this.
Right, that loop to the lungs.
Right. The pulmonary artery is special because it carries deoxygenated blood that's dropped off its oxygen to the body, away from the right side of the heart, heading to the lungs.
To pick up more oxygen.
Exactly. Then, the pulmonary veins carry that freshly oxygenated blood right back from the lungs to the left side of the heart, specifically the left atrium, ready to be pumped out to the rest of the body by the left ventricle.
Okay, so we got oxygen in the blood, the heart is pumping it around. Now, how do we gauge how well all of this is working? That's where cardiac output comes in, doesn't it?
Precisely. Cardiac output, often just called CO, is the total amount of blood your heart pumps out every single minute.
Every minute, okay.
And it's calculated simply by multiplying the stroke volume, how much blood per beat, by the heart rate, how many beats per minute. So stroke volume times heart rate equals cardiac output.
Simple formula, huge implications.
Absolutely. Cardiac output directly affects perfusion, how much blood reaches the lungs to get oxygenated, and how much oxygenated blood gets delivered to all your tissues.
So a low cardiac output is a serious problem for oxygenation then.
A huge problem. If your heart isn't pumping strongly enough, your CO is low. That means less blood flows to the lungs, so less blood gets oxygenated. That can lead to hypoxemia, low oxygen levels in your blood.
Right.
And even if your lungs are working perfectly, if your cardiac output is low, that oxygen-rich blood can't be efficiently delivered to your tissues. That can cause hypoxia, low oxygen at the tissue level, or symptoms that look very much like it.
And the document points out how poor breathing, hypoventilation, can make things even worse if CO is already low.
Yes, it's a double whammy. If you're not breathing deeply or frequently enough, hypoventilating carbon dioxide builds up in your blood and your oxygen levels drop. Combine that with a low cardiac output.
And you've got serious trouble.
You've got a double hit.
Yeah.
Poor oxygen pickup in the lungs and poor oxygen delivery to the rest of the body. It's a downward spiral.
It's all so interconnected. The document also describes a dangerous cycle involving something called afterload and chronic hypoxemia.
Yeah, this is a critical concept, especially in chronic lung disease.
Yeah.
In conditions like COPD, where there's often long-term low oxygen in the blood, that's chronic hypoxemia.
Okay.
The blood vessels in the lungs can actually constrict over time.
Yeah.
This leads to pulmonary hypertension, high blood pressure, specifically in the arteries of the lungs.
High pressure in the lungs, right.
This increased pressure increases the afterload on the right ventricle. Think of afterload as the resistance the right side of the heart has to pump against to get blood into the lungs. It's like trying to push open a door that's really heavy or stuck.
Makes the heart work much harder.
Exactly. Over time, this extra workload can weaken the right ventricle and lead to right-sided heart failure, which, of course, further reduces cardiac output and makes oxygenation even worse.
A really concerning downward spiral, like you said. And there was a clear example using heart failure itself to illustrate this connection.
Yes, in heart failure, the heart muscle weakens, its contractility decreases, and therefore cardiac output drops.
Right.
This reduced blood flow means less oxygen reaches both the lungs for pickup and the body's tissues for delivery. This directly causes common heart failure symptoms like shortness of breath, fatigue, and, well, hypoxia.
So it's not just the mechanics of the heart's pumping. Problems with its electrical system can also throw things off significantly, right? The document discusses the cardiac conduction system and mechanical dysfunction link.
Exactly. They are tightly linked. The electrical conduction system needs to be working perfectly to coordinate those powerful mechanical contractions.
Yeah.
If the electrical impulses don't start correctly in the SA node, or if they get blocked or travel too slowly through the heart.
Like a short circuit.
Kind of, yeah. It can lead to dysrhythmias or abnormal heart rhythms. These rhythm problems, like beating too fast, too slow, or just irregularly, can directly impair the heart's ability to fill properly and pump blood effectively. That directly impacts cardiac output.
Makes sense. If the rhythm's off, the pump doesn't work well.
Precisely. The document also mentions that if the heart muscle itself is damaged, say, from a heart attack, myocardial infarction, or in chronic heart failure, it physically won't be able to eject enough blood with each beat. Again, lower stroke volume, lower cardiac output.
And then we have issues with the heart valves, those one-way doors.
Right. If a valve becomes narrowed and stiff, that's called stenosis. It obstructs blood flow.
Harder to push through.
Exactly. Or if it doesn't close completely and leaks backward, that's regurgitation.
Right.
Both of these disrupt the normal, smooth forward flow of blood and can significantly reduce the effective cardiac output.
Okay.
The heart has to work harder to compensate.
And we can't forget myocardial ischemia when the heart muscle itself doesn't get enough oxygen. That sounds critical.
It is. This happens when the coronary arteries, the arteries supplying blood to the heart muscle, become narrowed, usually by plaque buildup. They just can't deliver enough oxygen-rich blood to meet the heart's demands, especially during exertion.
So what happens then?
The two main consequences are angina, which is that characteristic chest pain or discomfort due to a temporary shortage of oxygen.
The warning sign.
Exactly. And myocardial infarction, a heart attack, which occurs when the blood flow is blocked for too long, leading to irreversible damage and death of heart muscle tissue. Both of these severely impact the heart's ability to pump effectively.
And can cause those dangerous dysrhythmias too.
Absolutely. Finally, the document touches on the difference between left-sided and right-sided heart failure.
Right. They affect different parts of the circulation.
Yes. Left-sided heart failure primarily affects the left ventricle, the main pumping chamber that sends oxygenated blood out to the body. When it weakens, blood and fluid can back up into the lungs.
Causing breathing problems.
Exactly.
Yeah.
Respiratory symptoms like shortness of breath, coughing, crackles in the lungs. Right-sided heart failure mainly affects the right ventricle, which pumps blood to the lungs. When it fails, blood tends to back up in the systemic circulation, the rest of the body.
So you see swelling elsewhere.
Right. You often see swelling in the legs, ankles, feet, peripheral edema, and sometimes enlargement of the liver or spleen. Often, left-sided failure can eventually lead to right-sided failure.
Okay, so many things can potentially go wrong with this incredibly intricate system. Now let's zoom out a bit. What are some of the broader factors that can influence someone's oxygenation levels? The document talks about age, lifestyle, and environment.
Yeah, these are all really significant influences. Age plays a role across the lifespan. Newborns and young infants have some initial protection from their mother's antibodies, but their respiratory systems are still developing, making them, more vulnerable to infections.
Their airways are smaller too.
Exactly. School-aged kids and teenagers might get exposed to more respiratory infections at school, and this is often when experimentation with smoking or vaping might start.
Big risk factor.
Huge. Young and middle-aged adults often face lifestyle-related risks, maybe poor diet, lack of exercise, chronic stress, smoking, substance use, all taking a toll.
And older adults.
And in older adults, the natural aging process itself brings changes. The chest wall can become stiffer, the lungs less elastic, heart valves might develop some calcification, plaque can build up in arteries, all of which can potentially impact oxygenation efficiency.
So those are the kind of inherent changes over time. And then we have the choices we make day to day, our lifestyle.
Absolutely. Good nutrition, staying well hydrated, getting regular physical activity, these all support a healthy cardiopulmonary system. On the flip side, smoking is just devastating for both the lungs and the blood vessels, no question.
Damages airways, reduces oxygen carrying.
Everything. Substance abuse also takes a significant toll, and chronic, unmanaged stress can contribute to things like high blood pressure, which impacts the heart.
And the environment we live in can also have an impact, can it? Air quality, things like that.
That's right. Air pollution is a big one. The document also gives an example, maybe slightly indirectly environmental, about rural populations potentially having higher rates of COPD. While complex, this might be linked to factors like higher smoking rates in some areas or occupational exposures, maybe farming dusts, things like that.
Right, complex interactions. So understanding these risk factors is a crucial first step in identifying potential oxygenation problems. The document then moves on to how healthcare professionals actually assess for these risks when they see a patient.
Yeah, this involves looking systematically at both respiratory and cardiac conditions, plus a whole range of other contributing factors. On the respiratory side, we're concerned about conditions that mess with gas exchange. Things like hyperventilation.
Or breathing too fast.
Right, blowing off too much CO2, which can cause dizziness, tingling. And the opposite, hypoventilation, breathing too shallow or slow, leading to a buildup of carbon dioxide and drop in oxygen.
Which can make you sleepy or confused.
Exactly. And of course, hypoxia is the overarching concern, that state of low oxygen in the body's tissues. That's what we're trying to prevent or treat.
And on the cardiac side of things, what flags go up?
We look for any disruptions in the heart's electrical rhythm, those dysrhythmias we talked about.
Yeah.
Problems with the heart valves not opening or closing properly, stenosis or regurgitation, myocardial hypoxia or ischemia, that lack of oxygen to the heart muscle itself, and conditions like cardiomyopathy, which is a disease of the heart muscle, making it weak or stiff.
Okay.
And we're also concerned about peripheral tissue hypoxia signs, that the arms and legs, the periphery, aren't getting enough oxygenated blood flow.
And there are other things, right? Things that can interfere with oxygen delivery, even if the lungs and heart seem okay initially.
Yes, definitely. A big one is anemia, having a lower than normal amount of hemoglobin or red blood cells. Hemoglobin is the taxi for oxygen, so fewer taxis means less oxygen delivery, even if the blood is fully saturated in the lungs.
Makes sense. Capacity is reduced.
Exactly. Also, a decrease in the concentration of oxygen in the air you're breathing, like going to high altitudes, obviously reduces the amount available to get into your lungs.
Right, less oxygen in each breath.
Increased metabolic demand is another factor. When your body's working harder, like during a high fever or intense exercise, it needs more oxygen. If supply can't keep up, you run into problems.
And physical limitations.
Yes, anything that restricts the movement of your chest wall can hamper breathing. Think about late-stage pregnancy, significant obesity, neuromuscular diseases that weaken breathing muscles, serious injuries to the chest, or even problems with the central nervous system centers that control breathing. All can impair ventilation and thus oxygenation.
Wow, quite a list. Chronic diseases also play a really significant role here, don't they? It's not just acute problems.
Absolutely fundamental. Chronic lung diseases like COPD or pulmonary fibrosis directly impair the ability to get oxygen into the blood and CO2 out. The document mentions the characteristic barrel chest, often seen in people with advanced COPD or cystic fibrosis.
Why does that happen?
It's a change in the shape of the chest due to chronic overinflation of the lungs. They can't fully exhale, so air gets trapped. Individuals with chronic lung disease frequently experience shortness of breath, or dyspnea, often rapid breathing, tachypnea, persistently low blood oxygen levels, hypoxemia, and sometimes high levels of carbon dioxide, hypercapnia.
And anemia again.
Yes, anemia can be a secondary complication of many chronic illnesses like kidney disease or chronic inflammation, and it further reduces the blood's capacity to carry that precious oxygen.
So, recognizing these potential risks then leads to looking for actual physical signs that someone is having oxygenation problems right now. How does a healthcare professional use their clinical judgment in this kind of assessment? What are they looking for?
It's a really critical skill, combining observation with measurement. It starts with careful observation and checking vital signs. We look closely at the person's breathing rate. Is it fast, slow, normal? And the effort, are they using extra muscles? Does it look difficult?
Labored breathing.
Exactly. Oxygen saturation, measured with that little finger clip,
What?
pulse oximetry, is key. Ideally, it should be above 95%, though acceptable levels might be slightly lower in some chronic conditions. We look at SpO2.
And heart rate.
Often, the heart rate will increase tachycardia as the body tries to compensate for low oxygen levels by pumping the blood faster. Blood pressure might also change.
Those are the objective measurements. What about the physical signs you can actually see on the patient?
Well, cyanosis is a classic, though often late sign. That's the bluish discoloration you might see in the lips, fingertips, earlobes, or around the mouth. It indicates severely low oxygen levels in the blood circulating near the skin.
That sounds serious.
It is. We also look for nasal flaring, especially in infants and children, and the use of accessory muscles, those muscles in the neck and chest that are normally used for quiet breathing. Seeing those kick in means they're really struggling to get enough air.
What about changes over time?
Clubbing of the fingers is one. That's a widening and rounding of the fingertips and nail beds that often develops slowly over time in people with chronic low oxygen levels, like in severe lung disease or some heart conditions.
Interesting. And mental status.
Hugely important, and often an early sign. A change in mental status. Things like confusion, restlessness, agitation, anxiety, or even unusual drowsiness can be one of the first signs that the brain isn't getting enough oxygen.
Good to know. And of course, listening to the lungs with a stethoscope is also a vital part of the assessment. What can that tell you?
A lot. Listening to breath sounds, auscultation is key. Crackles, sometimes called rales, are popping sounds that might indicate fluid in the small air sacs, like in pneumonia or heart failure.
Fluid sounds.
Wheezing is that high-pitched whistling sound, suggesting narrowed airways, typical in asthma or COPD exacerbations. And diminished or even absent breath sounds in certain areas could point to a collapsed lung segment, pneumothorax, or a significant blockage preventing air entry.
So different sounds mean different problems. What about circulation signs?
We also pay attention to the skin and extremities. Cool, pale skin can be a sign of poor blood flow, vasoconstriction, or low cardiac output. And we check capillary refill time.
How do you do that?
You press briefly on a nail bed until it blanches white, then release and see how quickly the normal pink color returns. Normal is very quick, under 2-3 seconds. A delayed capillary refill suggests that oxygenated blood isn't getting delivered to the peripheral tissues effectively.
Okay. And all of these findings need to be considered together, right, in the context of the patient's overall medical history.
Exactly. Clinical judgment means putting all the pieces together. Knowing if the person has a history of conditions like asthma, COPD, pneumonia, anemia, heart disease, recent surgeries, injuries, exposure to toxins, or even recent travel to higher altitudes. All that provides crucial context for interpreting the current signs and symptoms.
It's like detective work. So if these oxygenation issues aren't recognized and addressed effectively, what are some of the potential negative health outcomes? The document lists quite a few serious possibilities.
Yeah, the consequences can be severe across different systems. Problems with the heart's electrical conduction, those dysrhythmias we mentioned, can lead to bradycardia, a dangerously slow heart rate, or tachycardia, a very fast one. Atrial fibrillation, that irregular and often rapid rhythm.
Increases stroke risk, right?
Significantly.
Right.
And various types of heart blocks where the electrical signal is delayed or stopped. These can cause symptoms like dizziness, fainting, syncope, persistent fatigue, and in severe cases, even sudden cardiac arrest.
Scary stuff. And what about when the heart just isn't able to pump enough blood effectively, that altered cardiac output we talked about? What are the downstream effects?
Low cardiac output directly leads to poor perfusion. This can result in hypotension, low blood pressure, weak pulses, cool and pale skin, edema or swelling, often in the legs or lungs, shortness of breath, and just profound fatigue. Critically, it can lead to dysfunction of vital organs like the kidneys and brain because they simply aren't receiving enough oxygen and nutrients to function properly.
Makes sense. Organs need that blood flow. What about impaired function of the heart valves if those doors aren't working right?
That also has significant consequences. You might hear abnormal heart sounds called murmurs when listening with a stethoscope. The inefficient pumping can cause the heart to become overloaded with fluid, leading to heart failure and fluid buildup in the lungs, known as pulmonary congestion.
Breathing issues again.
Yes. There's also an increased risk of blood clots forming within the heart chambers, particularly with valve problems like atrial fibrillation. People often have reduced exercise capacity, and there's even an increased risk of infection settling on the damaged valves, called endocarditis.
And myocardial ischemia, that lack of oxygen to the heart muscle itself. We talked about angina and heart attack.
Right. Beyond the immediate pain of angina or the damage of a heart attack, ischemia can trigger those dangerous heart rhythm problems, arrhythmias. It can acutely worsen or lead to chronic heart failure. And tragically, a severe ischemic event or its resulting arrhythmia can cause sudden death.
Finally, impaired tissue perfusion when oxygenated blood isn't reaching the body's tissues effectively, maybe due to low CO or blocked arteries. What are the outcomes there?
This affects the whole body, but often shows up first in the extremities. We might see pale and cold arms and legs, the delayed capillary refill we mentioned, altered mental status again as the brain is affected. If it's severe or prolonged, it can cause actual organ damage.
Like kidney failure.
Exactly. Or even tissue necrosis, the death of tissue, leading sometimes to gangrene or the need for amputation. You can get non-healing ulcers, profound fatigue, and a dangerous buildup of acid in the body called metabolic acidosis because cells switch to less efficient energy production without oxygen.
It's a stark reminder of how absolutely crucial this oxygen delivery system is. And as the document emphasizes, if these conditions go untreated, they can lead to permanent organ damage and ultimately death. A very sobering thought.
It really is. It underscores why recognizing and managing oxygenation issues is so fundamental to healthcare.
So when a patient is experiencing altered oxygenation, what's the overall plan of care? What are the key goals healthcare teams are working towards?
Well, the overarching goals are generally focused on restoring and maintaining adequate oxygenation. This usually means aiming to keep their oxygen saturation level, that's SpO2, above 92%, although the specific target might vary based on the individual and their condition.
Okay, keep the O2 levels up.
Right. Maintain a healthy respiratory rate, typically aiming for somewhere between 12 and 20 breaths per minute for an adult, and ensuring the depth and pattern of breathing are effective. If they're prescribed an incentive spirometer, that little device you breathe into to encourage deep breaths, a goal would be for them to use it correctly and frequently to help keep the lungs expanded and clear.
Promote deep breathing.
Exactly. Maintaining a clear airway is absolutely critical. This might involve helping them cough effectively, suctioning secretions if needed, or positioning them optimally. And ultimately, ensuring the patient can tolerate any necessary procedures to help clear their airway, or even tolerate the support of mechanical ventilation or other artificial airways if their condition requires it.
So those are the targets. Now, how do nurses use their clinical judgment to figure out the specific problems the nursing diagnoses and decide on the right interventions to help improve oxygenation? The document breaks this down into different settings: health promotion, acute care, and restorative care. Let's start with health promotion.
Okay. In health promotion, the focus is really on preventing oxygenation problems before they even start, or catching them super early. Nurses use their judgment to identify individuals who are at higher risk, maybe smokers, older adults, people with certain occupations or pre-existing conditions.
Proactive identification.
Exactly. And recognizing any subtle early warning signs of potentially impaired oxygenation, like maybe a noticeable decrease in their ability to tolerate their usual activities, or perhaps a new persistent cough. Common nursing diagnoses at this stage might include things like risk for impaired gas exchange, or ineffective health maintenance if lifestyle factors are involved, or maybe readiness for enhanced self-health management.
And the interventions.
Interventions here are all about education and preventative measures. Big ones are smoking cessation programs and support, recommending and facilitating vaccinations like flu and pneumococcal vaccines, encouraging regular appropriate exercise, providing guidance on good nutrition and hydration, and teaching effective breathing exercises like pursed lip breathing or diaphragmatic breathing, especially for those with early lung issues.
That's all about being proactive. What about when someone is already experiencing acute oxygenation issues, like in a hospital setting?
Right. In acute care, the focus shifts dramatically to managing the immediate respiratory problem. Nurses need sharp assessment skills to interpret vital signs, oxygen saturation readings, maybe arterial blood gas results. They have to quickly recognize signs of respiratory distress or impending failure, like that increased work of breathing, cyanosis, confusion.
High stakes.
Definitely. And prioritizing immediate actions is key. Nursing diagnoses here are going to be things like impaired gas exchange, ineffective airway clearance, maybe activity intolerance due to shortness of breath, or risk for aspiration.
And the actions taken?
Interventions are often immediate and direct. Administering supplemental oxygen as ordered, maybe via nasal cannula or mask. Positioning the patient strategically, often sitting upright like in a high Fowler's position to help their lungs expand more easily.
Helping them breathe easier?
Exactly. Suctioning the airway to remove secretions if the patient can't clear them effectively. Closely monitoring their respiratory status, listening to lung sounds frequently, and giving prescribed medications, maybe bronchodilators to open up the airways, corticosteroids to reduce inflammation, antibiotics if there's an infection. This often involves close collaboration with respiratory therapists too.
Makes sense, team effort. And what about for individuals with long-term or chronic respiratory conditions, when they're maybe back home or in rehabilitation?
So in restorative and continuing care, the goal is to support their long-term recovery, help them manage their chronic condition as effectively as possible, and maximize their quality of life. Nurses continuously monitor for any ongoing changes or complications. They identify any barriers the patient might face in managing their own care at home, maybe difficulty using equipment or affording medications.
Practical challenges.
Right. And evaluating how well things like home oxygen therapy or non-invasive ventilation devices are actually working for them. Nursing diagnoses in this phase might include chronic ineffective breathing pattern, self-care deficit related to their respiratory limitations, risk for infection, or maybe ineffective coping.
So interventions are focused on long-term management.
Exactly. Things like developing a comprehensive plan for using home oxygen safely and effectively, teaching strategies for conserving energy during daily activities, referring them to pulmonary rehabilitation programs, which combine exercise training, education, and support to improve lung function and exercise tolerance, and providing ongoing education and support to ensure they adhere to their medications, understand their condition, and connect with available community resources or support groups.
The document really emphasizes the ongoing nature of this process, that evaluation piece. It's not just do something and walk away.
Absolutely not. It's a continuous cycle. Assess, diagnose, plan, implement, evaluate. If a particular intervention isn't producing the desired results, if their oxygen levels aren't improving or they're not tolerating an activity, you need to go back, reevaluate the situation, figure out why it's not working, and adjust your approach accordingly. It's constant clinical reasoning.
That makes perfect sense. Now, let's shift our focus a little bit because the document also delves into something that might seem a bit separate at first glance, but is clearly considered important: the influence of spirituality on a patient's health practices and well-being.
It is indeed. And it's included because a person's overall sense of well-being, their inner resources, can have a really significant impact on their physical health outcomes, and especially on their ability to cope with illness, stress, and loss.
So there are tangible benefits.
The document highlights research suggesting that individuals with a stronger sense of spiritual health often experience benefits like decreased perception of pain, lower levels of anxiety, potentially increased adherence to treatment plans because they feel more hopeful or motivated, maybe even lower mortality rates in some studies, and just an overall improved quality of life.
Interesting.
It can foster feelings of joy, forgiveness, connection, and a greater sense of inner peace or purpose, which are powerful buffers against the challenges of illness.
That makes a lot of sense. When someone feels a sense of purpose and connection, it likely strengthens their resilience. The document also touches on the concepts of faith, hope, and spiritual well-being specifically. How are they defined here?
Faith is described generally as a deep sense of trust or belief in something beyond oneself, often, but not always, involving a higher power or guiding principles. Hope is characterized as the expectation of a positive outcome or continued endurance, even when facing difficult circumstances. It's that forward-looking orientation.
Believing things can get better or be bearable.
Exactly. And spiritual well-being is presented as this broader concept encompassing an overall feeling of peace, purpose, and connection. And that connection can be multifaceted connection to oneself, to others, to nature, or to the sacred or transcendent, however the individual defines that.
So these concepts are interconnected and can provide a powerful source of inner strength.
That's the idea. They can be really crucial resources for coping and resilience, especially during times of health crises.
And there's an important distinction often made between spirituality and religion, isn't there?
Yes, the document points that out. Spirituality is generally seen as a broader, more personal concept. It focuses on an individual's unique journey, their search for meaning and purpose in life, death, and existence, their values, their sense of connection.
More individualized.
Right. Religion, on the other hand, is typically understood as a more organized and structured system of beliefs, practices, rituals, and often a defined community of worship associated with a specific denomination or faith tradition. While they often overlap, a person can be spiritual without being religious, or vice versa.
Got it. So how do healthcare professionals become aware of a patient's potential spiritual needs or resources? It seems like a sensitive area.
It definitely requires sensitivity and respect. The document mentions the importance of being attentive to cues. Maybe the patient mentions prayer, talks about their faith community, has religious items with them, or expresses existential questions about meaning or suffering. It also notes various spiritual assessment tools that can help guide these conversations respectfully, including the FICA tool.
FICA, what does that stand for?
FICA is a common acronym used to structure a brief spiritual assessment. It stands for F, faith, or beliefs. Do you consider yourself spiritual or religious? Or do you have spiritual beliefs that help you cope? Identify importance and influence. How important are these beliefs in your life? Have they influenced how you take care of yourself? C, community. Are you part of a spiritual or religious community? Is this support for you? And A, address. How would you like me, as your healthcare provider, to address these issues in your care?
That seems like a helpful framework to open the door gently.
Yeah, it's designed to be patient-centered and respectful, allowing the patient to share as much or as little as they are comfortable with. Being attuned to these needs is considered an important part of providing holistic, person-centered care.
And how does clinical judgment then guide the interventions aimed at supporting a patient's spiritual health if they desire it?
Well, the judgment comes in recognizing that addressing spiritual needs, when welcomed by the patient, can genuinely contribute to better coping mechanisms, reduce stress and anxiety, maybe even a lower risk of depression associated with their illness.
So it's part of the overall therapeutic plan.
Potentially, yes. Interventions don't have to be complex. Sometimes it's as simple as establishing presence, just spending meaningful time with the patient, actively listening without judgment, showing empathy. It's about acknowledging them as a whole person.
Being there.
Exactly. It also involves supporting a healing relationship. This means considering the patient beyond just their physical symptoms, understanding how their illness impacts their life, their values, their sense of self, and their goals. It might involve facilitating connections with spiritual care providers like chaplains if the patient wishes, supporting their religious practices if appropriate and feasible, or simply respecting their need for quiet reflection or prayer.
It sounds like it's about supporting their existing resources and coping mechanisms.
Very much so. It's about partnering with the patient to access the sources of strength and meaning that are important to them.
Shifting to another very important and often sensitive area, the document addresses caring for loss, grief, and death. This is an unavoidable part of healthcare and life, requiring a great deal of compassion and skill.
Absolutely. And the nurse's role in these situations is multifaceted and incredibly important. The document describes the nurse as a comforter, providing solace and support during incredibly difficult times. As an educator, helping patients and families understand what to expect, perhaps regarding the dying process or grief. As an advocate, ensuring the patient's wishes regarding end-of-life care and their family's needs are heard and respected. And as a witness, simply acknowledging the significance of their journey, their life, and their loss with empathy and professionalism.
Honoring their experience, it also mentions different types of loss that people experience. It's not always about death, is it?
No, loss is broader than that. The document outlines several categories. Necessary loss is described as a loss that's a natural part of life changes, often replaced by something different, like children growing up and leaving home. You lose their daily presence, but gain a new phase of life.
Expected changes.
Right. Maturational loss is related to normal developmental transitions, like a toddler experiencing separation anxiety when starting daycare, or an older adult losing some physical capabilities. Situational loss is sudden, unpredictable, often traumatic, resulting from a specific event like losing a job, a natural disaster destroying a home, or a loved one dying unexpectedly in an accident.
More sudden and external.
Yes. Actual loss is the tangible loss of something or someone that can be recognized by others, like the death of a spouse, the loss of a limb, or losing a valued object. And perceived loss is more internal and subjective, defined by the individual experiencing it, even if it's not obvious to others. For example, a loss of confidence after a setback, or the perceived loss of status after retirement.
So loss can take many forms. And then there's the process of grief that individuals often go through in response to loss. The stages are often mentioned.
Yes, the document lists the commonly recognized stages, often attributed to Elizabeth Kubler-Ross: denial, anger, bargaining, depression, and acceptance. However, it's really important to remember that grief is a highly personal and nonlinear experience.
People don't just tick off boxes in order.
Exactly. People don't necessarily move through these stages in a neat sequence. They might revisit stages, experience them in a different order, or some stages might be more prominent than others. It's more of a framework for understanding common reactions than a rigid roadmap.
Good point. And grief itself can manifest in many different ways, some more complicated than others.
That's right. The document distinguishes several types of grief. Normal grief, sometimes called uncomplicated grief, is a natural response to loss involving a wide range of common emotional, cognitive, social, physical, and spiritual reactions. It's painful, but the person gradually adapts over time.
The expected response, though, is still hard.
Yes. Anticipatory grief can occur before the actual loss happens, like when a loved one has a terminal illness. People may start grieving the future losses while the person is still alive.
Grieving what's coming.
Right. Disenfranchised grief is grief related to a loss that isn't openly acknowledged, socially sanctioned, or publicly mourned. Examples might include the loss of a pet, a terminated pregnancy, the death of an ex-spouse, or loss due to suicide, where stigma can interfere with support.
Hidden or unsupported grief.
Exactly. And then there's complicated grief, also called persistent complex bereavement disorder in some classifications. This is characterized by prolonged, intense, and debilitating grief that significantly interferes with daily life and functioning long after the loss.
When grief gets stuck.
Essentially, yes. This can take various forms, including chronic grief, where the intense reactions continue for years without resolution. Exaggerated grief, where the person experiences overwhelming reactions that might include self-destructive behaviors or psychiatric disorders. Delayed grief, where the emotional reaction is significantly postponed, sometimes for months or years. Or masked grief, where the person isn't consciously aware that their current behaviors or physical symptoms are actually related to the unresolved loss.
Wow, grief is complex. The document provides some specific examples of how grief, particularly complicated grief, might manifest in a person's life.
Yes, it gives examples like prolonged and intense crying spells occurring frequently, even years after the loss. A significant increase in alcohol or substance use as a coping mechanism. The development of new, persistent physical symptoms like heart palpitations, headaches, or digestive issues. Excessive avoidance of anything or anyone that reminds them of the deceased or the loss. Or a pervasive feeling that life has lost its meaning or purpose. A deep sense of emptiness.
These sound like red flags that someone needs more support.
They definitely indicate that the grieving process isn't progressing in a healthy way, and intervention might be needed.
And there are a multitude of factors that can influence how any individual responds to grief, right? It's not the same for everyone.
Absolutely not. The document lists many variables: their current emotional state and mental health, their usual coping mechanisms and personality style, the personal meaning they attach to the person or thing that was lost. How significant was it?
The nature of the relationship.
Exactly. Any other losses they've experienced recently or accumulated over their lifetime? Changes in their family structure or roles resulting from the loss? The quality and availability of their social support network, their overall physical health, any cultural, religious, or spiritual beliefs and rituals surrounding death and grief.
Practical things, too.
Yes, their financial situation and any stressors related to that. The circumstances surrounding the loss was sudden, expected, traumatic. The timeline of the illness or prognosis leading to the loss, if applicable. How decisions were made surrounding the end of life or the loss itself. Any substance use issues the griever might have. Changes in their sleep patterns and weight. Their general level of grief intensity. And crucially, their ability to carry out their normal daily activities and maintain functioning. All these factors interact.
It's incredibly individual, so developing a nursing care plan to support someone who is grieving requires a very thoughtful and highly individualized approach then.
Absolutely. It always begins with a thorough, compassionate assessment, considering all those influencing factors we just discussed. What is this specific person's experience? Based on that assessment, appropriate nursing diagnoses are identified, such as grieving or complicated grieving or maybe risk for spiritual distress.
Tailoring the diagnosis.
Right. Then, realistic and collaborative goals are established with the patient or family. What do they hope to achieve? Maybe it's simply being able to verbalize their feelings about the loss without being overwhelmed, or perhaps finding ways to memorialize their loved one.
Patient-centered goals.
Always. And finally, specific nursing interventions are planned, with clear rationales for each. These interventions are geared towards supporting the grieving process. Examples might include providing a safe, private, and supportive space for them to express their emotions, anger, sadness, guilt, whatever comes up. Using therapeutic communication techniques, active listening, reflecting feelings, offering silence. Helping them identify and utilize their existing coping strategies and support systems, providing information about the grief process, maybe connecting them with bereavement support groups or counseling services if needed.
And evaluating progress.
Continuously. Evaluating whether the interventions are helping them move through their grief and adjusting the plan as needed. It's a supportive partnership through a difficult journey.
And in the specific context of end-of-life care, there are particular interventions aimed at managing symptoms and providing comfort and dignity.
Yes, palliative care principles are central here. Interventions include assisting the patient and their family with making informed decisions about end-of-life care options, respecting their values and preferences. Providing expert palliative care focused on symptom management, or referring to hospice care when appropriate.
Managing pain, breathing.
Exactly. Effectively managing physical symptoms like pain, shortness of breath, nausea, anxiety, using both pharmacological and non-pharmacological approaches. Using therapeutic communication to address their emotional, social, and spiritual needs and fears. Offering comprehensive psychosocial support to both the patient and their family. And always striving to maintain the patient's dignity, comfort, and sense of self-worth throughout the dying process.
That focus on dignity seems paramount. Advanced directives are also incredibly important in end-of-life care. What exactly is their purpose, and what is the nurse's role regarding these documents?
An advance directive is a legal document that allows individuals to communicate their wishes regarding medical treatment in the event that they become unable to make those decisions for themselves in the future, perhaps due to illness or injury. It empowers patients to maintain control over their care.
Planning ahead.
Exactly. This typically includes documents like a living will, which specifies the types of medical treatments they would or would not want, like mechanical ventilation or artificial nutrition, and a durable power of attorney for healthcare, sometimes called a healthcare proxy or agent, which designates a specific person to make healthcare decisions on their behalf if they become incapacitated.
So what's the nurse's role?
The nurse has several key roles. As an educator, explaining what advanced directives are, why they're important, and helping patients understand the options available. As an advocate, supporting the patient's right to make these decisions free from coercion and ensuring their documented wishes are known and respected by the healthcare team. As a communicator, documenting the existence and content or absence of an advanced directive in the patient's medical record and communicating this information clearly to other providers. And as a source of support, offering compassionate presence and guidance during these often difficult conversations with patients and families about future care preferences.
It's about facilitating patient autonomy. Okay, let's shift gears quite significantly now to a topic that underlies virtually all aspects of patient care: medication administration. The document outlines both the crucial legal responsibilities and the physiological principles involved.
Right. It's a huge area of nursing practice with major safety implications. From a legal standpoint, medication administration is governed by a complex web of regulations. You have federal laws, like FDA regulations, state and local laws, the specific policies and procedures of the healthcare institution you work in, and very importantly, the state's Nurse Practice Act.
Which defines what nurses can legally do.
Precisely. It defines the scope of a nurse's responsibilities regarding medications. Physiologically, we need to understand two key areas: pharmacokinetics and pharmacodynamics.
Okay, break this down.
Pharmacokinetics is essentially what the body does to the drug. It involves four main processes: absorption, how the drug gets into the bloodstream; distribution, how it travels to different tissues; metabolism, how the body breaks it down, usually in the liver; and excretion, how the body gets rid of it, often via the kidneys.
ADME: absorption, distribution, metabolism, excretion.
You got it. Pharmacodynamics, on the other hand, is what the drug does to the body. This includes its intended therapeutic effects, why we're giving it, but also any unintended adverse effects, side effects, potential for tolerance, allergic reactions, or toxicity.
How the drug acts. Okay. There are also different phases and types of medication actions that we need to consider when giving drugs, aren't there? Things like onset, peak.
Yes, understanding the time course of drug action is critical for safe and effective dosing. We look at the onset of action, how quickly the drug starts to have a noticeable effect. The peak concentration when the drug reaches its highest level in the bloodstream, which is often, but not always, when its effect is strongest. The trough level, the lowest concentration of the drug in the body, usually measured just before the next dose is due, important for drugs with a narrow therapeutic window.
Making sure it doesn't get too low or too high.
Exactly. The duration of action, how long the drug's effect actually lasts, and the plateau, which is a steady level of drug concentration achieved in the body with repeated regular doses, aiming to keep the drug level within the therapeutic range consistently.
So timing is crucial. And how do developmental factors, like a person's age, influence how medications work in their body? Does the document touch on that?
It mentions it as a general concept. Age can definitely have a significant impact on pharmacokinetics, that ADME process. For example, infants and very young children may have immature liver enzyme systems and reduced kidney function, which can affect how quickly they metabolize and eliminate drugs, potentially leading to buildup.
So doses need careful adjustment.
Absolutely. Older adults, conversely, often experience a gradual decline in organ function, particularly liver and kidney function, which slows down metabolism and excretion. They might also have changes in body composition, less muscle, more fat, lower levels of plasma proteins for drugs to bind to, and are often taking multiple medications, polypharmacy, increasing the risk of interactions and adverse effects.
More complex picture in older adults. And beyond just age, what other individual factors can come into play that influence how a medication acts?
Oh, quite a few. The document lists several. A person's body weight and overall body composition matter for dosing and distribution. Their genetic makeup is increasingly recognized. Pharmacogenetics looks at how inherited variations influence drug response, why some people metabolize certain drugs faster or slower than others.
Personalized medicine implications.
Big time. Gender can sometimes play a role due to differences in hormones or body composition. Obviously, the current function of their liver and kidneys is critical for metabolism and excretion. The specific route by which the medication is administered dramatically affects absorption and onset.
Pill versus 4, big difference.
Huge. Any other medications, supplements, or even certain foods they might be consuming can lead to drug interactions, altering the effects. Whether they have developed a tolerance, requiring higher doses for the same effect, or physical dependence on the drug, psychological factors like the placebo effect or patient expectations. And even the specific time of day the medication is given can sometimes influence its actions due to the body's natural circadian rhythms.
It's a really complex interplay of factors healthcare professionals need to consider for each patient. And of course, alongside the desired effects, we always need to be vigilant for any adverse events related to medications. What types are mentioned?
Right, safety is paramount. Adverse events can include predictable side effects, which are known, often unavoidable, secondary effects of a drug at therapeutic doses, like drowsiness with some antihistamines. Toxic effects occur when a drug accumulates in the body to dangerous levels, often due to overdose, impaired excretion, or accumulation over time.
Too much drug.
Basically, idiosyncratic reactions are unpredictable, unusual responses to a medication that occur in a small percentage of individuals, often due to genetic factors, and are not dose-related in the usual way. And allergic reactions involve the body's immune system mounting a response against the drug, ranging from mild rashes to severe, life-threatening anaphylaxis.
Need to watch for all of those. When deciding on the best way to give a medication the route of administration, there are many things to weigh, aren't there? Pros and cons for each.
Yes, definitely. The choice of route depends on the drug itself, the desired speed of onset, the patient's condition, and practical considerations. Oral medications, pills, liquids, are usually the most convenient and economical, but their absorption can be variable, affected by food, stomach acid, and the drug has to pass through the liver first pass effect, which can inactivate some of it.
Slower, maybe less predictable.
Can be. Parenteral routes like intravenous IM, intramuscular IM, subcutaneous sub-Q injections bypass the digestive system, offering faster, more complete, and predictable absorption. But they're more invasive, require sterile technique, carry a higher risk of infection, can be painful, and are often more expensive.
Faster, but more risks.
Generally. Topical medications are applied directly to the skin, usually for local effects, like creams or ointments. Transdermal patches provide a controlled, sustained release of medication through the skin into the bloodstream over hours or days.
Like nicotine or pain patches.
Exactly. Medications given via mucous membranes like sublingual, under the tongue, buccal, in the cheek. Nasal sprays or rectal suppositories can be rapidly absorbed into the bloodstream, bypassing the liver initially. Inhalation delivers drugs directly to the lungs, great for respiratory conditions. And intraocular discs are placed in the eye to provide a slow, steady release of medication over time. Each route has its place.
Lots of options. The document also clearly outlines the distinct but collaborative roles of different healthcare professionals in the whole medication administration process. It's a team effort.
Absolutely essential. The prescribing healthcare provider, doctor, nurse practitioner, physician assistant, is responsible for assessing the patient, determining the need for medication, selecting the appropriate drug, dose, route, and frequency, and writing the legal order or prescription.
The order starts there.
Right. The pharmacist plays a crucial role next. They review the prescription for accuracy, safety, checking for potential interactions, allergies, contraindications, prepare and dispense the medication accurately, and often provide important information and counseling to the patient and other healthcare providers. They're a key safety checkpoint.
The medication expert.
Exactly. And the nurse is typically the one who ultimately administers the medication to the patient safely and accurately at the bedside or in the clinic. This involves much more than just handing over a pill.
Right. It involves assessment, judgment.
Absolutely. It includes verifying the medication order against the medication administration record, MAR, performing those crucial safety checks, assessing the patient before and after administration, ensuring the 7 rights are met, monitoring the patient's response, therapeutic effects and adverse effects, providing patient education about their medications, documenting everything accurately, and advocating for the patient's safety if any concerns arise about the order.
Those 7 rights are really the cornerstone of safe medication administration, aren't they? Could you list them? And there's also the concept of the 3 checks associated with them.
They are indeed fundamental principles drilled into every nurse. The 7 rights are: 1, the right medication; 2, given to the right patient; 3, in the right dose; 4, via the right route; 5, at the right time; 6, for the right reason, indication, ensuring the drug makes sense for the patient's condition; 7, followed by the right documentation recording it accurately.
7 critical checkpoints.
Yes. And the 3 checks are a systematic process nurses use to verify these rights at different points during medication preparation and administration, acting as safety nets to catch potential errors.
Okay, what are the 3 checks?
The first check happens when the nurse initially retrieves the medication container or unit dose package. They compare the label directly against the MAR or the provider's order. Check 1. Right med, patient, dose, route, time. The second check occurs while preparing the medication. For example, pouring a liquid, drawing up an injection, getting the pills ready. Compare the medication label again to the MAR. Check 2. Still right. The third check is done right at the patient's bedside, immediately before administering the medication to the patient. Compare the med label one last time to the MAR and often scan barcodes if technology is used. Check 3. Final verification before giving it.
3 distinct checks to catch errors, and preventing medication errors is absolutely paramount in healthcare. They can have serious consequences.
It is of utmost importance. Medication errors are unfortunately common, but many are preventable. Meticulously following the 3 checks and the 7 rights is a crucial strategy. Nurses also need to have a thorough understanding of the medications they are administering, their actions, usual dosages, side effects, know their patients, their allergies, other medications, relevant medical history, kidney liver function, and critically, always question any order that seems unclear, inappropriate, or unsafe. Never assume. Clarify doubts with the prescriber or pharmacist.
Never hesitate to question.
Never. Double-checking calculations, especially for high-risk medications, being aware of look-alike, sound-alike drugs, minimizing distractions during preparation, these are all vital error prevention strategies.
Patient education is another really vital component mentioned for safe and effective medication use. How does that fit in?
It's absolutely essential for adherence and safety, especially when patients are managing medications at home. The nurse plays a key role here. Using methods like the teach-back technique is highly effective. Instead of just asking, "Do you understand?" well, you ask the patient to explain back to you in their own words how they will take their medication, what it's for, what side effects to watch for. It confirms their actual understanding.
Makes them actively process it.
Exactly. Assessing their health literacy, can they read and understand the labels and instructions? Having them actually demonstrate how to use devices like inhalers, insulin pens, or eye drops is also very important to ensure they can do it correctly. Providing clear written instructions, maybe in the preferred language, is also helpful. The goal is to empower the patient to be an active, informed partner in their medication therapy.
Empowered patients are safer patients. Finally, after a medication has been given, the process doesn't just end there. We need to evaluate the patient's response, right?
That's right. Evaluation is a critical part of the nursing process for medications. It involves carefully observing for the intended therapeutic effect. Is the pain relieved? Is the blood pressure lower? Is the infection clearing? Monitoring for any side effects or adverse reactions. Did they get drowsy, develop a rash, experience nausea?
Looking for good and bad effects.
Both. Assessing objective data, like changes in vital signs, lab results, either ample blood glucose after insulin, clotting times after anticoagulants. Asking the patient how they are feeling subjectively. How is your pain level now? Are you feeling dizzy? Documenting all relevant findings, the medication given, the patient's response, any interventions taken for side effects clearly and accurately in the medical record, and reassessing the patient's condition regularly to determine if the medication is working as expected, if the dose needs adjustment, or if the therapy needs to be changed. It closes the loop.
A continuous cycle of care. Now, the document also includes a section on diabetes, shifting focus again, this time to how the body regulates blood sugar. This is another huge area with significant implications for overall health, including cardiovascular health and potentially oxygenation down the line.
Definitely. Diabetes is a chronic metabolic disorder characterized by persistently high levels of glucose or sugar in the blood. This hyperglycemia, if not properly managed, can lead to serious damage to blood vessels and nerves throughout the body over time, causing a wide range of long-term health problems.
What are the main types discussed?
The document focuses on the two most common types, type 1 and type 2 diabetes. Type 1 diabetes is primarily an autoimmune disease where the body's own immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas. As a result, the body produces very little or absolutely no insulin.
So they need external insulin.
Exactly. It typically has a younger age of onset, often in childhood or adolescence, though it can occur at any age. People with type 1 require daily insulin injections or the use of an insulin pump for survival, as insulin is essential to allow glucose to enter cells for energy.
And type 2?
Type 2 diabetes is much more common, accounting for maybe 90–95% of cases. It's characterized primarily by insulin resistance, where the body's cells don't respond effectively to the insulin that is being produced. Over time, the pancreas may also gradually lose its ability to produce enough insulin to compensate.
So the insulin isn't working well, or there isn't enough.
Right, often a combination. It's strongly linked to lifestyle factors like obesity, physical inactivity, and unhealthy diet, as well as genetic predisposition. It's more common in adults, though increasingly seen in younger people too. Initially, it's often managed with lifestyle modifications, diet changes, weight loss, exercise, but many people eventually require oral medications or even insulin to maintain blood glucose control.
Different underlying mechanisms. The document also provides a useful comparison of two serious acute complications of diabetes: diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, HHS. How do they differ?
They're both medical emergencies caused by uncontrolled high blood sugar, but they have key differences highlighted in the comparison table. Diabetic ketoacidosis, DKA, is much more commonly seen in individuals with type 1 diabetes, though it can occur in type 2 under stress. It usually develops relatively quickly, maybe over hours to a day or two.
What causes it?
It's triggered by a severe lack of insulin. Without insulin, the body can't use glucose for energy, so it starts breaking down fat instead. This fat breakdown produces acidic compounds called ketones, which build up in the blood, leading to metabolic acidosis, hence the ketoacidosis. Blood glucose is high, but often not as astronomically high as in HHS. Ketones are present in urine and blood, and the acidosis is a key feature.
Acidic blood, ketones present, and HHS.
Hyperosmolar hyperglycemic state, HHS, is more often seen in people with type 2 diabetes, especially older adults, often triggered by an illness or infection. It tends to develop more gradually, maybe over days or weeks.
Slower on.
Yes. It's characterized by extremely high blood glucose levels, often much higher than in DKA, leading to severe dehydration, because all that sugar pulls water out of the cells and into the bloodstream, eventually overwhelming the kidneys. The key difference is that in HHS, there's usually still just enough insulin present to prevent the widespread fat breakdown, so significant ketone production and acidosis are typically absent or minimal. The main problem is the extreme hyperglycemia and resulting hyperosmolality, very concentrated blood, and profound dehydration. Mental status changes are often more severe in HHS due to the extreme dehydration and hyperosmolality affecting the brain.
So, DKA, type 1 more often, faster onset, ketones, acidosis, HHS. Type 2 more often, slower onset, extreme glucose dehydration, minimal ketones, acidosis.
Got it.
And diabetes, if not well controlled over the long term, can lead to a multitude of chronic complications affecting various parts of the body.
Yes, unfortunately. Chronic high blood sugar levels act almost like a toxin, damaging both small blood vessels, microvascular complications, and large blood vessels, macrovascular complications, as well as nerves.
What parts of the body are most affected?
Common long-term complications include damage to the eyes, retinopathy, potentially leading to blindness, damage to the kidneys, nephropathy, which can lead to kidney failure requiring dialysis or transplant, damage to nerves, neuropathy, causing pain, numbness, or tingling, especially in the feet and hands, and also affecting autonomic nerves controlling functions like digestion and blood pressure. Increased risk of diseases affecting the brain, like stroke, greatly increased risk of heart disease and heart attack due to damage to large blood vessels, atherosclerosis, and problems with the extremities, particularly the feet, due to poor circulation and nerve damage, leading to slow-healing ulcers, infections, and sometimes necessitating amputations.
A truly systemic disease. So managing diabetes effectively requires a really comprehensive and ongoing approach, doesn't it?
Absolutely. It's a lifelong commitment for most people. Key components of diabetes management outlined include following a healthy eating plan tailored to their needs, engaging in regular physical activity, which helps improve insulin sensitivity, monitoring blood sugar levels, frequently using a glucose meter or continuous glucose monitor, CGM, to see how food, activity, stress, and medications affect their levels.
Checking sugars regularly.
Essential. Learning to recognize and promptly treat both low blood sugar, hypoglycemia, and high blood sugar, hyperglycemia. Taking prescribed medications as directed, whether they're oral medications or insulin injections. Performing regular self-monitoring for potential complications, especially daily foot checks for any sores or changes, regular skin checks, and routine eye exams.
Preventative care.
Yes. Managing necessary supplies, like test strips, lancets, insulin, syringes, or pens. Learning strategies for coping with the emotional and psychological stress that often accompanies managing a chronic illness, and working with their healthcare team to manage other associated risk factors, particularly high blood pressure and high cholesterol, which further increase cardiovascular risk in people with diabetes. It requires a lot of self-management education and support.
It really sounds like a full-time job for the patient. Another really important topic that the document covers, relevant to so many conditions, is understanding pain, which is often referred to as that fifth vital sign, the body's signal that something isn't right. It delves into the physiological processes involved in what's called nociceptive pain.
Right. Nociception is the basic neurological process of encoding noxious stimuli, things that are potentially damaging to tissues. It's the pathway that can lead to the subjective experience we call pain. It involves four main stages, as described in the document. First is transduction. This happens at the peripheral nerve endings, the nociceptors. A painful stimulus like heat, pressure, or chemical irritation from injury is converted into an electrical signal, an action potential.
Stimulus to electricity.
Exactly. Second is transmission. That electrical signal travels along the peripheral nerve fibers up to the spinal cord. From there, it ascends via specific pathways up to the brain, primarily the thalamus and then the cerebral cortex.
Signal goes up to the brain.
Third is perception. This is when the brain actually becomes aware of and interprets the signal. It involves conscious awareness in the cortex, integrating emotional responses from the limbic system. This is where the signal becomes the feeling of pain, with all its unpleasant qualities.
Brain registers, ouch.
Pretty much. And fourth is modulation. This is fascinating. The body isn't passive. The nervous system can actually influence or modify the pain signal as it travels. There are descending pathways from the brain back down to the spinal cord that can release natural pain-relieving chemicals, like endorphins and serotonin, which can inhibit or dampen the ascending pain signal. This is why things like distraction or relaxation techniques can sometimes reduce perceived pain.
The body can turn the volume up or down.
In a way, yes. Modulation is complex, involving both inhibitory and facilitatory mechanisms. Imagine you touch a hot stove, that initial ouch, the signal racing, the brain recognizing it, and maybe rubbing your hand afterwards to modulate the sensation that's nociception and pain perception in action.
Okay, that's the basic pathway. And there are different classifications of this nociceptive pain based on where it originates in the body.
Yes, the document distinguishes between somatic and visceral nociceptive pain. Somatic pain arises from tissues like the skin, muscles, connective tissues, bones, and joints. It's often well localized. You can usually point right to where it hurts, and typically described as aching, throbbing, sharp, or dull. Think of a cut, a bruise, arthritis pain, or a muscle sprain.
Pain from the body's framework.
You're right. Visceral pain originates from the internal organs like the intestines, bladder, uterus, liver, or heart. It often results from things like tumor involvement, obstruction, ischemia, lack of blood flow, or inflammation of an organ. Visceral pain tends to be more diffuse. Poorly localized, it might be felt over a general area rather than a specific spot, and often described as a deep, aching, cramping, squeezing, or pressure-like sensation. It can sometimes be referred to other areas too.
Pain from the organs, harder to pinpoint. Recognizing the cues a patient gives, both verbal and nonverbal, can really help in understanding what type of pain they might be experiencing, can't it? Differentiating is key.
Absolutely. Clinical judgment relies heavily on interpreting these cues. We listen for how they describe the pain, the quality, sharp, dull, burning, tingling, the location, and if it radiates, the intensity using pain scales, the timing, when did it start, is it constant or intermittent?
Yeah.
But beyond nociceptive pain, we also need to consider other categories.
Like?
Well, differentiating acute versus chronic pain is fundamental. Acute pain typically has a sudden onset, is usually short in duration, less than 3 to 6 months, has an identifiable cause, like surgery or injury, and serves a protective purpose. Chronic pain persists for longer than the expected healing time, may not have a clear ongoing cause, and often loses its protective function, becoming a disease state in itself, frequently associated with significant psychological distress and functional impairment.
Acute is a warning, chronic is the problem itself.
Often, yes. Then within those broad categories, we try to determine the underlying mechanism. Is it nociceptive pain, that somatic or visceral type we just discussed, related to tissue damage? Or is it neuropathic pain?
Nerve pain.
Exactly. Neuropathic pain results from damage to or dysfunction of the nerves themselves, either peripheral nerves or in the central nervous system. It's often described very differently. Common descriptors are burning, tingling, shooting, stabbing, electric-like sensations, numbness, or pins and needles. Examples include diabetic neuropathy, postherpetic neuralgia, shingles pain, or pain after spinal cord injury.
Different quality, different source.
Right. And we also need to consider referred pain, where pain is felt in a location distant from the actual source. A classic example is shoulder pain during a heart attack, caused by shared nerve pathways. So, careful assessment helps categorize the pain, which then guides treatment.
And there are a number of factors beyond the physical injury that can influence an individual's actual experience of pain, aren't there? It seems very subjective.
It is highly subjective and influenced by many factors. The document lists several. Age can play a role. Pain perception and expression might change across the lifespan. Fatigue often lowers pain tolerance. Genetic predispositions can influence sensitivity to pain and response to analgesics. The integrity and function of their neurological system is obviously key.
Social and psychological factors, too.
Definitely. Social factors like the level of support from family and friends, previous experiences with pain, positive or negative, and attention focusing on pain tends to amplify it, while distraction can reduce it. Psychological factors are huge. Anxiety, fear, depression often worsen pain perception, while coping skills and a sense of control can improve it. And cultural factors significantly shape how pain is expressed, interpreted, and managed.
How so? Cultural factors.
Well, for example, some cultures might encourage stoicism and minimizing outward expression of pain, while others might encourage more open expression. Beliefs about the meaning of pain or acceptable methods for relief can also vary widely. Facial expressions associated with pain might even differ subtly across cultures. Healthcare providers need to be culturally sensitive and avoid making assumptions based on their own background.
Good point. So, how does a healthcare professional put all this together and use their clinical judgment when assessing a patient's pain? It sounds like more than just asking, rate your pain 0 to 10.
Oh, much more. That number scale is just one tool. A comprehensive pain assessment using clinical judgment involves several steps, as outlined. First, recognize cues. Gather all the relevant information. This includes the patient's self-report, the most reliable indicator, nonverbal cues, grimacing, guarding, restlessness, changes in activity, vital sign changes, though these can be unreliable, especially in chronic pain, their behavior and relevant medical history, past surgeries, injuries, conditions.
Collect all the data.
Second, analyze cues and prioritize hypotheses. Interpret the information gathered. Use pain assessment tools like numeric scales, verbal descriptor scales, or FACES scales appropriately. Determine the probable type of pain, acute to chronic, nociceptive, neuropathic. Use frameworks like PQRST, provoking, palliating factors, quality, region, radiation, severity, timing, to get a detailed description. Consider potential underlying causes and prioritize, is this likely simple post-op pain, or could it be something more serious like a complication that needs urgent attention? Rule out red flags.
Figure out what's likely going on.
Third, Generate solutions and take action. Based on the assessment, develop a plan. Select appropriate pain relief interventions, maybe non-pharmacological measures first, or starting with analgesics based on the type and severity of pain. Communicate effectively with the patient about the plan and with the rest of the healthcare team. Implement the chosen interventions safely.
Choose and do the right things.
Fourth, evaluate outcomes. This is crucial. Reassess the patient's pain regularly after interventions using the same scale or method used initially. Ask about pain relief achieved. Monitor for any side effects of treatments. Evaluate their functional status. Are they able to move more, rest better? And adjust the treatment plan based on this evaluation. Did it work? If not, why not? And what's next?
Continuous loop again. You mentioned contrasting acute and chronic pain. That the document lists specific characteristics for each, which seems useful for differentiation.
Yes, it's a helpful comparison. Acute pain typically has an identifiable cause: injury, surgery, inflammation, recent onset, limited duration, resolves and tissue heals, serves a protective purpose, warns of damage, often accompanied by observable physiological signs, increased heart rate BP, sweating though not always, and responds well to analgesics.
Often has an unclear or persistent cause, or the original injury healed but pain persists, lasts longer than 3 to 6 months, serves no apparent protective purpose, intensity can fluctuate, physiological signs often adapt and normalize, so vitals may be normal, frequently associated with psychological effects, depression, anxiety, fatigue, sleep disturbance, functional impairment, and can be more challenging to treat, often requiring a multimodal approach.
Different beasts entirely. And when it comes to pharmacological management using medications, there are different categories of analgesic drugs that can be used.
That's right. The main categories mentioned are non-opioids, which include acetaminophen, like Tylenol, and non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen or naproxen. These are generally used for mild to moderate pain, and NSAIDs also have anti-inflammatory effects. Acetaminophen works differently, primarily in the central nervous system.
The common over-the-counter options often.
Often, yes, but they have dosage limits too. Then there are opioids like morphine, oxycodone, hydrocodone, fentanyl. These act on opioid receptors in the central nervous system and are typically used for moderate to severe pain. They are very effective but come with significant risks, including sedation, respiratory depression, constipation, and the potential for tolerance, dependence, and addiction.
Powerful but risky.
Definitely need careful management. And then there are adjuvants, or co-analgesics. These are medications that have primary indications other than pain, but have been found to be effective for certain types of pain, especially neuropathic pain. Or they can enhance the effects of opioids, allowing for lower doses. Examples include certain antidepressants, like TCAs or SNRIs, anticonvulsants, like gabapentin or pregabalin, corticosteroids, and muscle relaxants.
Using other meds to help with pain.
Exactly, often in combination.
There are also important nursing guidelines highlighted that need to be followed to ensure the safe administration of these pain medications, especially opioids.
Absolutely critical due to the potential risks. Key guidelines include: always obtain a thorough patient history, including allergies, previous experiences with analgesics, what worked, what didn't, any side effects, substance use history, and other medical conditions.
Know your patient.
Crucial. If more than one analgesic is ordered, e.g. an opioid and a non-opioid, use clinical judgment to select the most appropriate one based on the patient's current pain assessment, type, and severity. Be meticulous about accurate dosage, know the usual dose range, be aware of maximum daily doses, especially for acetaminophen and NSAIDs to avoid liver or kidney toxicity, and double-check calculations.
Dose limits are important.
Very. Consider the timing and interval carefully. For persistent pain, like post-op or cancer pain, around-the-clock ATC dosing is often more effective than waiting for pain to become severe, PRN or as-needed dosing. PRN doses are better for intermittent or breakthrough pain. Consider giving analgesics before painful procedures or activities.
Proactive dosing.
Yes. Avoid intramuscular IM injections for pain relief if possible, especially in older adults, as absorption can be unreliable and they can cause tissue damage. Use sustained release or long-acting formulations for managing chronic, stable pain, but ensure immediate release options are available for breakthrough pain. And critically, avoid abrupt cessation of opioids in patients who have been taking them regularly and have likely developed physical tolerance, as this can cause withdrawal symptoms. Tapering is usually necessary.
Gradual reduction. Clinical judgment really guides the decision-making process when choosing between non-pharmacological and pharmacological approaches to pain management, or often how to combine them.
It absolutely does. It's not always about reaching for the pills first. The process involves, first, a comprehensive assessment of the patient's pain type, severity, location, duration, impact on function, as we discussed. Then considering the patient's overall medical condition, age, any risk factors for specific treatments like kidney disease for NSAIDs or risk of falls with opioids, their preferences, values, and previous experiences.
Consider the whole picture.
Right. Non-pharmacological methods should almost always be considered, either alone for mild pain or as adjuncts for moderate to severe pain. The document provides examples like applying heat or cold, massage, positioning, acupuncture, transcutaneous electrical nerve stimulation, TENS, distraction techniques, music, conversation, imagery, relaxation exercises, deep breathing, meditation, physical therapy. These can be very effective and have fewer side effects. They're often particularly useful for chronic pain management.
Using non-drug methods first or alongside.
Exactly. Pharmacological approaches are chosen based on the type and intensity of the pain, following principles like the WHO analgesic ladder, starting with non-opioids, adding opioids for moderate pain, using stronger opioids for severe pain. The choice of drug, route, and dose is tailored to the individual, aiming for the lowest effective dose for the shortest necessary duration, especially with opioids. It's always a patient-centered decision-making process, involving discussing the risks and benefits of different options with the patient.
Shared decision-making. There can also be various barriers, unfortunately, that hinder effective pain management in practice. What are some examples?
Yes, despite our best efforts, barriers exist. The document lists several. Environmental factors within the healthcare system itself can be barriers. Things like time constraints for nurses to do thorough assessments, staffing shortages, inadequate knowledge among some healthcare providers about pain management principles, restrictive policies or regulations regarding opioid prescribing.
System issues.
And then there are individual factors related to the patient or provider. Patient barriers might include reluctance to report pain, fear of being seen as complaining, fear of side effects or addiction, cultural beliefs about pain or stoicism, communication difficulties, language barriers, cognitive impairment, or lack of understanding about their treatment options. Provider barriers might include inadequate assessment skills, personal biases or fears about opioids, or concerns about regulatory scrutiny. Addressing these barriers is crucial for improving pain care.
Recognizing them is the first step. And just like with assessing oxygenation or medication effects, it's crucial to evaluate how a patient responds to the pain management interventions that are implemented. You can't just give a painkiller and assume it worked.
Absolutely not. Evaluation is key. The document stresses the importance of factual, objective, and timely assessment of the patient's response. Use the same pain scale or method consistently to track changes. Ask the patient directly about their pain relief, how much better is your pain now, and document their response clearly. Monitor for and manage any side effects. If the pain isn't adequately controlled or if side effects are problematic, the plan needs to be reassessed and modified. It's an ongoing process of titration and adjustment to achieve the best possible balance between pain relief and side effects.
Fine-tuning the approach. Okay, the document also touches on the growing field of complementary and alternative therapies, sometimes called CAM, which offer options beyond conventional Western medical treatments. What's the difference between complementary and alternative?
That's a key distinction. Complementary therapies are used alongside or in addition to conventional medical treatments, like using acupuncture to help manage side effects of chemotherapy. Alternative therapies are used in place of conventional medical treatments, like choosing herbal remedies instead of prescribed medication for a condition. Integrative healthcare is a term often used now that emphasizes combining conventional and evidence-informed complementary therapies in a coordinated way.
So complementary is with, alternative is instead of.
Generally, yes. And integrative healthcare aims to bring the best of both worlds together, focusing on the whole person.
What's the emphasis in integrative healthcare, and what's the nurse's role?
Integrative healthcare emphasizes the importance of the patient-practitioner relationship, focusing on the whole person, mind, body, spirit, and community, not just the disease. It's informed by evidence and makes use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. The nurse's role in this model is often highlighted because nurses traditionally spend significant time with patients, building therapeutic relationships, and are well positioned to understand the patient's physical, emotional, and spiritual needs, and coordinate care across different providers and therapies.
Taking that holistic view, what are some clinical applications of relaxation therapies specifically? How can they help patients?
Relaxation therapies encompass a variety of techniques aimed at reducing stress and tension. The document notes clinical applications like lowering blood pressure and heart rate, decreasing muscle tension, improving overall feelings of well being, and reducing symptoms associated with stress, such as anxiety, insomnia, fatigue, and even pain perception. They can be really valuable tools for stress management and symptom control in many different health conditions.
And there are several complementary therapies mentioned that nurses can often implement independently without needing a specific order as part of patient care.
Yes, depending on their training, institutional policies, and the specific patient situation, nurses can often teach and guide patients in techniques like basic relaxation exercises, like progressive muscle relaxation, simple meditation practices and breathing exercises, and guided imagery. These are generally low-risk interventions that can empower patients with self-care tools.
These sound like valuable tools. Could you briefly describe the principles behind how they work and their potential effectiveness? Let's start with guided imagery.
Guided imagery involves using the power of your mind, your imagination, to create vivid mental images that promote relaxation, well-being, or specific healing goals. A nurse or a recording might guide the patient to imagine a peaceful scene, focusing on sensory details, sights, sounds, smells, feelings, which can help shift focus away from pain or anxiety and elicit the body's relaxation response. It's based on the mind-body connection. Studies suggest it can be effective for reducing pain, anxiety, and stress.
Using the mind to influence the body. What about meditation and breath work?
Meditation encompasses various practices, but many involve focusing attention maybe on the breath, a word, an object, or just observing thoughts without judgment to quiet the mind, increase awareness, and promote a state of calmness and relaxation. Breath work involves consciously controlling or paying attention to your breathing pattern. Techniques like slow, deep abdominal breathing can directly activate the parasympathetic nervous system, the body's rest and digest system, which counteracts the stress response, slowing heart rate and lowering blood pressure. Both meditation and breath work have strong evidence supporting their effectiveness for stress reduction, anxiety management, improving focus, and promoting emotional regulation.
Simple but powerful techniques.
Yeah.
And just like with conventional treatments, it's important to evaluate a patient's response to these complementary therapies too, right?
Absolutely. It's crucial for several reasons. First, safety, ensuring the therapy is appropriate and not causing any adverse effects. Second, effectiveness, determining if it's actually helping the patient achieve their goals. Example, reduced anxiety, better sleep. Third, personalization, tailoring the approach based on the patient's preferences and response. And fourth, empowerment, involving the patient in evaluating what works for them, reinforces their active role in their own health and well-being.
Makes sense. Finally, the document wraps up with sections on perioperative nursing, caring for patients through the whole surgical experience in fluid, electrolyte, and acid-base balance, which is fundamental to homeostasis. Let's tackle perioperative nursing first. What are the phases?
Right. Perioperative nursing covers the continuum of care for surgical patients and is typically divided into three distinct phases. The preoperative phase. This begins when the decision for surgery is made and continues right up until the patient is transferred onto the operating room table. During this phase, the nurse's role is crucial. It involves things like taking a detailed health history and performing a physical assessment to identify risks, providing patient and family education about the procedure and what to expect afterwards, ensuring informed consent is properly obtained and documented, initiating necessary preparations like starting 5 lines or administering pre-op medications, and providing emotional support to alleviate anxiety.
Getting the patient ready.
Exactly, the intraoperative phase. This spans the time from when the patient enters the operating room or procedure area until they are transferred to the post-anesthesia care unit, ACU, or recovery room. Here, the nurse's focus shifts to patient safety within the OR environment. This includes roles like scrubbing in and assisting the surgeon, or circulating managing the OR environment, ensuring sterile technique is maintained, coordinating the care provided by the surgical team, documenting events, and advocating for the patient who is often unconscious or sedated.
Safety during the surgery itself.
Paramount. The post-operative phase. This begins with the patient's admission to the PACU and continues through their recovery, discharge from the PACU, and potentially includes care on a surgical unit until they are healed or discharged home. In the immediate PACU phase, the nurse's absolute priorities are monitoring and stabilizing the patient's airway, breathing, and circulation, ABCs, assessing their level of consciousness as they emerge from anesthesia, managing pain and nausea, monitoring the surgical site dressing and any drainage, and preventing immediate complications. The Electrolyte score is a common tool used here to assess readiness for transfer from the PCU.
Recovery and watching for problems. Assessing surgical risk factors before surgery is a really important part of that preoperative phase, isn't it? Why is that so critical?
It's absolutely critical for planning safe care and anticipating potential complications. The document highlights several key risk factors nurses assess for. Smoking is a big one. It impairs wound healing and increases respiratory complications. Age very young and elderly patients often have higher risks. Nutritional status, malnutrition, or obesity can affect healing and increase risks. Obesity itself brings risks like difficult airway management and VTE. Obstructive sleep apnea, OSA, significantly increases risks of respiratory complications after anesthesia.
Breathing issues.
Major ones. Immunosuppression, whether from disease or medications, increases infection risk. Pre-existing fluid and electrolyte imbalances need correction before surgery if possible. A history of postoperative nausea and vomiting, POMV, or postoperative urinary retention, POUR, suggests these might recur. And assessing the risk for venous thromboembolism, VTE, blood clots like DVT or PE, is standard practice, as surgery and immobility increase this risk significantly.
So identifying these helps tailor the care plan. What about pre-existing medical conditions, comorbidities? They also increase risks, right?
Yeah, definitely. The presence of comorbid conditions significantly impacts postoperative outcomes. Examples include respiratory diseases like COPD or asthma increase the risk of breathing problems after anesthesia. Cardiovascular diseases like heart failure, hypertension, or coronary artery disease increase cardiac risks. Diabetes can impair wound healing and increase infection risk, plus blood sugar control can be challenging around surgery. Obesity, as mentioned, adds multiple risks. Kidney or liver disease affects how medications and anesthetic agents are metabolized and excreted. Neurological disorders might affect recovery from anesthesia or positioning during surgery. Immunosuppression from conditions like HIV or cancer treatments increases infection risk. And substance use, including alcohol or illicit drugs, can affect anesthesia requirements and increase withdrawal risks post-op. Careful management of these conditions before, during, and after surgery is crucial.
Requires careful planning. And the nurse plays a vital role in promoting patient safety throughout the entire perioperative period, not just during one phase.
Absolutely. Patient safety is the overarching goal. Key nursing roles in promoting safety include ensuring clear and effective communication and handoffs between all members of the healthcare team, surgeons, anesthesiologists, nurses, promoting optimal glycemic control for patients with diabetes, implementing strict infection prevention measures, hand hygiene, sterile technique, appropriate antibiotic administration, taking meticulous steps to prevent pressure injuries, especially during long surgeries when patients are immobile, and actively participating in protocols designed to prevent serious preventable errors known as never events, things like wrong site surgery or retained foreign objects. Using surgical safety checklists is a standard part of this.
Checklists are key. And in that immediate postoperative period, once the patient lands in the PCU, what are the absolute top nursing care priorities?
The absolute non-negotiable top priority is assessing and maintaining a patent airway and ensuring adequate breathing and oxygenation, the ABCs. That comes before everything else.
Airway, breathing, circulation.
Always. Closely monitoring vital signs, heart rate, blood pressure, respiratory rate, oxygen saturation, temperature, and the patient's level of consciousness as they wake up from anesthesia is also critical. Nurses need to frequently assess the surgical dressing for any excessive bleeding or drainage, check any drains that might be in place, manage intravenous fluids carefully to maintain hydration without overloading, and assess and manage the patient's pain effectively. Evaluating their recovery from anesthesia, often using a standardized tool like the Electrolyte score, which looks at activity, respiration, circulation, consciousness, and oxygen saturation, helps determine when they are stable enough to be safely transferred from the PCU to the next level of care or potentially discharged home if it was outpatient surgery.
A period of intense monitoring. Okay, lastly, the document discusses the absolutely crucial topic of fluid, electrolyte, and acid-base balance, maintaining the body's internal equilibrium, homeostasis. It lists a number of common imbalances that can occur.
Yes, maintaining this balance is fundamental to all physiological processes. Disruptions can be life-threatening. Common imbalances include acid-base imbalances like acidosis, too much acid or too little base, or alkalosis, too much base or too little acid, which can be respiratory or metabolic in origin. Electrolyte imbalances involving key ions like potassium, K plus hypohyperkalemia, sodium, Na plus hypohypernatremia, magnesium, Mg plus hypohypermagnesemia, and calcium, Ca plus hypohypercalcemia, Each electrolyte has vital roles, and levels that are too high or too low cause some specific problems.
Like heart rhythm issues with potassium.
Exactly. And fluid volume imbalances. This can involve fluid volume deficit, FVD, also known as dehydration or hypovolemia, where there's insufficient fluid in the body, or fluid volume excess, FVE, also called hypervolemia, or fluid overload, where there's too much fluid. These can be further broken down into isotonic imbalances, where water and electrolytes are lost or gained in proportion, or osmolality imbalances, where the concentration of solutes changes, leading specifically to hypernatremia or hyponatremia. The document details specific causes and sign symptoms for each type of fluid imbalance. Clinical dehydration is noted as a specific combination of FED and hypernatremia.
Lots of ways for fluids and electrolytes to get out of whack.
Hmm.
And there are many different risk factors that can predispose someone to developing these imbalances, right?
Yes, very common in healthcare settings. Risk factors include age infants and older adults are particularly vulnerable due to differences in body fluid composition and less effective compensatory mechanisms. Environmental factors like extreme heat causing excessive sweating. Significant losses of fluids and electrolytes through the gastrointestinal tract, think severe vomiting, diarrhea, or GI suctioning.
Losing fluids fast.
Right. Chronic diseases play a huge role. Conditions like kidney disease impairs regulation, heart failure can cause fluid retention, lung disease affects acid-base balance, endocrine disorders like diabetes or adrenal problems, trauma, burns, or surgery often cause significant fluid shifts and losses. And various medical therapies themselves can contribute diuretics, IV fluids, if not managed carefully, certain medications.
So vigilance is needed for many patients. Being able to interpret basic laboratory values is essential for identifying and managing these electrolyte problems specifically.
Absolutely critical. Nurses need to know the normal ranges for key electrolytes and understand the clinical significance of deviations. For example, potassium, normal, 3.5 to 5.0 MEQL. Hypokalemia, low K+, can cause muscle weakness, fatigue, constipation, and dangerous cardiac dysrhythmias. Hyperkalemia, high K+, can cause muscle cramps, weakness, paralysis, and life-threatening cardiac arrest. Sodium, normal, 135, 145 millieql. Hypernatremia, low Na+, symptoms depend on whether it's associated with fluid deficit, excess, or normal volume, but can include confusion, headache, seizures, coma. Hypernatremia, high Na+, often involves thirst, lethargy, weakness, irritability, seizures, coma, usually related to dehydration. Calcium, normal, 8.5, 10.5 mg/dL, ionized level is different. Hypercalcemia, low Mk+, can cause lethargy, weakness, confusion, bone pain, kidney stones, nausea, vomiting. Magnesium, normal, 1.5 to 2.5 millieql. Hypomagnesemia, low Mg+, often causes neuromuscular excitability, tremors, tetany, seizures, confusion, and cardiac dysrhythmias. Hypermagnesemia is less common but can cause lethargy, decreased reflexes, respiratory depression, bradycardia. Knowing these helps recognize problems early.
Understanding the labs is key to knowing what's wrong. And the overall nursing process, assessment, diagnosis, planning, implementation, evaluation, is applied systematically to the care of patients with these complex fluid, electrolyte, and acid-base imbalances.
Exactly. It provides that essential framework. Assessment involves gathering history, physical exam findings like checking skin turgor, edema, vital signs, lung sounds, mental status, monitoring intake and output, and reviewing lab results. Diagnosis involves identifying the specific imbalance, e.g. fluid volume deficit related to vomiting. Planning involves setting goals, e.g. patient will have balanced intake and output within 24 hours, and choosing appropriate interventions. Implementation involves carrying out those interventions, like administering 5E fluids or electrolyte replacements, monitoring response. And evaluation involves continuously reassessing the patient to see if the imbalance is resolving and adjusting the plan as needed.
The same systematic approach. Intravenous therapy is a very common and essential intervention for addressing fluid and electrolyte imbalances. But it's used for other concerns too, right?
Yes. IV therapy is a cornerstone of modern healthcare with many purposes. The document lists several key ones. Fluid and electrolyte replacement is a major use, correcting deficits or maintaining balance when oral intake is inadequate. Administering medications directly into the bloodstream for rapid effect or when oral route isn't feasible. Providing nutritional support through parenteral nutrition, TPN, when the GI tract can't be used. Transfusing blood products, red cells, platelets, plasma. maintaining venous access for anticipated future treatments or emergencies, and delivering chemotherapy or other specialized infusions. It's incredibly versatile.
A lifeline for many patients. And accurately measuring and recording a patient's fluid intake and output, INSO, is a fundamental nursing responsibility in monitoring their fluid balance, especially when they're getting IV fluids or have risks.
It's a really crucial aspect of basic nursing care, though sometimes challenging to do accurately. Accurate measurement and thorough documentation of all fluids taken in, oral liquids, IV fluids, tube feedings, and all fluids eliminated, urine, emesis, diarrhea, drainage from tubes, are essential for assessing fluid balance, identifying trends, and detecting potential problems like fluid overload or dehydration early.
Who need strict INO monitoring?
Typically, patients who are acutely ill, have heart failure or kidney disease, are receiving IV fluids, have significant fluid losses, like post-op patients with drains, or those with severe diarrhea are receiving diuretics, or have known or suspected fluid electrolyte imbalances. Guidelines emphasize frequency, using calibrated containers, avoiding contamination, examining the characteristics of output like urine color clarity, most importantly, evaluating trends over time, not just isolated numbers.
Watching the trends. But 5V therapy itself, while essential, can also have potential complications that nurses need to be constantly watching for and know how to manage immediately.
Yes, unfortunately, complications can occur. Nurses need to be vigilant in assessing 5E sites and monitoring patients. Common complications include infiltration, where the AV fluid leaks out of the vein into the surrounding subcutaneous tissue, causing swelling, coolness, and pain at the site. Phlebitis, inflammation of the vein itself, characterized by redness, warmth, pain, tenderness along the vein, and sometimes a palpable cord. Extravasation, this is more serious. It's the leakage of a vesicant, a medication that can cause tissue damage, blistering, or necrosis into the surrounding tissue. Requires immediate action to minimize damage.
Vesicants sound dangerous.
They are. Other complications include local infection at the IV site. Signs are redness, warmth, swelling, purulent drainage. Air embolism, a rare but potentially life-threatening complication where air enters the bloodstream through the IV line, can cause respiratory distress, chest pain, hypotension. Fluid overload, or circulatory overload, where the body receives too much IV fluid too quickly, leading to shortness of breath, crackles in the lungs, distended neck veins, edema. And catheter embolism, where a piece of the IV catheter breaks off and enters the bloodstream, also rare but serious. For each of these, nurses need to know the signs and the immediate nursing actions, usually stopping the infusion, assessing the patient, notifying the provider, and implementing specific interventions depending on the complication.
Stop the infusion first for most local issues. Finally, the document outlines the specific procedure for administering a blood transfusion and the critical steps for managing any potential transfusion reactions. This is definitely a high-risk procedure, demanding meticulous attention to detail.
Extremely high risk, yes. Errors can have fatal consequences. The procedure involves several non-negotiable safety steps. First, carefully verifying the physician's order for the specific blood product and ensuring informed consent is obtained. Then, performing a thorough pre-transfusion assessment of the patient, including baseline vital signs. Gathering all necessary supplies, correct IV tubing with filter normal saline solution.
Getting ready.
Then the critical step. Obtaining the correct blood product unit from the blood bank and performing a meticulous verification at the patient's bedside. This must be done by 2 licensed healthcare professionals, often 2 RNs or an RN and a physician. They compare the information on the blood unit tag directly with the patient's wristband and the transfusion order, checking patient name, ID number, blood type, ABO and RH, unit number, expiration date. Any discrepancy means SDOP, do not transfuse.
Double, triple check everything.
Absolutely. Once verified, the transfusion is initiated, typically using normal saline alongside. It's started slowly for the first 15 minutes, and the nurse must stay with the patient during this critical period, monitoring closely for any signs of a transfusion reaction, like fever, chills, hives, itching, shortness of breath, back pain, nausea, changes in vital signs.
Watch like a hawk initially.
Yes. If no reaction occurs, the infusion rate can be increased as ordered. Vital signs are monitored frequently throughout the transfusion according to policy. The entire unit must generally be completed within 4 hours from the time it left the blood bank to minimize the risk of bacterial contamination at room temperature. If any signs of a reaction occur at any point, the transfusion must be stopped immediately, the IV line kept open with normal saline, the provider notified immediately, and emergency procedures followed based on the type and severity of the reaction. Saving the blood bag and tubing for the blood bank is also crucial for investigation.
Stop immediately if reaction suspected. Wow, we've truly covered an immense amount of interconnected information today, all stemming from that one comprehensive document. It's remarkable to see just how intricately the seemingly separate functions of breathing, blood circulation, fluid balance, and even things like pain and medication effects work together to maintain oxygenation and overall health.
It really is striking, isn't it? What stands out to me is how a seemingly simple act, like breathing, relies on such a delicate interplay of pressure gradients, that negative intrapleural pressure, and coordinated muscle contractions. And the fact that subtle changes, like confusion or restlessness, can be such an early indicator of hypoxia really highlights how incredibly sensitive the brain is to even small drops in oxygen delivery.
Absolutely. And that direct link between the heart's pumping ability, the cardiac output, and both how well the lungs can oxygenate the blood and how effectively that oxygen reaches the tissues, that connection is just fundamental.
You can't separate them. One affects the other immediately.
Exactly. And for you, our listener, this deep dive really underscores the incredible complexity, but also the resilience of your own body. Understanding these fundamental processes, how you breathe, how your heart works, how oxygen gets around, really emphasizes the importance of making those healthy lifestyle choices we talked about. Things like avoiding smoking, staying physically active, managing stress, maintaining a well-balanced diet. They aren't just abstract recommendations. They directly support these absolutely vital systems.
Which then raises a fascinating question for you to consider thinking forward.
Hmm.
Given the body's remarkable ability to compensate for early, subtle imbalances in oxygenation, fluid balance, or even blood sugar before major symptoms appear, how might future advancements in technology, maybe wearable sensors, continuous monitoring devices, AI analysis, play a role in detecting these changes even earlier, maybe even before we become clinically obvious?
Proactive health monitoring.
Exactly. It's worth thinking about the potential for truly proactive and personalized healthcare focused on maintaining that delicate internal balance, perhaps catching problems when they're much easier to manage. What could that look like in the years to come?
Definitely some fascinating food for thought. Well, thanks for joining us for this deep dive into the cardiopulmonary system, oxygenation, and so many related concepts. Until our next exploration.